All right, to all who are new here, welcome. My name is Dr. Michelle Henney, and I'd like to welcome you to Releve Sports Medicine's Virtual Journal Club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar or sign up for the email list to be notified of upcoming webinars. We are continuing to update our schedule, so check back often. This video will be available for review after this journal club. The information contained in the video content represents the views and opinions of the presenters and does not necessarily represent the views or opinions of Releve Sports Medicine. The mere appearance of video content on the website does not constitute an endorsement by RSM or its affiliates of such video content. The video content has been made available for informational and educational purposes only. The video content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard a professional medical advice or delay in seeking it because of something you have read or seen on the site. RSM hereby disclaims any and all liability to any party for any direct, indirect, implied, punitive, special, incidental, or other consequential damages arising directly or indirectly from any use of the video content, which is provided as is and without warranties. We are looking for an athletic trainer to join our team. This is a full-time clinic-based physician working in a sports medicine clinic. Please feel free to pass our information along if you know of a qualified candidate. More information regarding applying can be found on our website. For all athletic trainers who are intending to get live CEUs from the BOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz, evaluation, and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customercare@gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. The recording will be available for review from the website tomorrow. Dr. Dressing is a pediatric sports medicine specialist at Joe DiMaggio Children's Hospital in South Florida. He cares for children and adolescents with sports medicine injuries and orthopedic concerns. This includes pediatric orthopedics, fracture care, overuse injuries, and concussion management. Dr. Dressing went to college at Notre Dame, to medical school at Wright State University, to residency at the University of South Florida in pediatrics, and to fellowship at University of Florida at Orlando Health for sports medicine. Currently, he works with many of the high school football teams in South Florida, providing sideline coverage in the fall. He sits on the medical advisory board of the Broward County Athletic Association. He is an affiliate physician for the Washington Nationals baseball team, as well as the LPGA. Previously, he has worked with many of the professional and amateur sports teams in Orlando and St. Petersburg, as well as the U.S. Men's Olympic beach soccer team. So I will hand it away here for Dr. Dressing to speak with us tonight about pediatric sports injuries.
All right, awesome. Thank you for having me. I'm happy to be here and talk to you about what I do on a daily basis, which is pediatric sports medicine and orthopedics. And I have a lot of kind of slides to run through, and I'll try to run through them fairly quick just to kind of give some time for questions at the end. I know a lot of this stuff may or may not be as relevant to you guys, and especially from an athletic training standpoint, it might be not as relevant, but maybe there's certain things that we want to talk about more than others. And a lot of the stuff I'm sure you talk about with sports injuries in general, and so maybe that won't be one of the highlights, but we definitely have plenty of different pediatric specific things to talk about as well. So let me try to get my screen up. Let's see, are you guys able to see that?
Not yet. Let me try. I'm going to just bop it back to here, and then I'm going to have that button pop back up.
Let's see. It's taking me to system preferences, but then it's not giving me an option to share my screen when I click that show button.
Okay. Do you happen to have a Mac?
I do.
Okay. What we may end up doing then is you might have to let me know when to hit forward. Sometimes with Macs we've run into some difficulties, and so I will and change it back to me. Okay, and hopefully you didn't change it since the last time you sent us a version.
I don't think so.
Okay.
All right, awesome. So awesome. Thank you for the introduction, Michelle. We met many years ago and we did the same fellowship, so we've stayed in touch over the years. And then the next slide, I have no anything to disclose or anything there. I wish I had some conflicts of interest, but no one has offered me any yet. So moving on, starting with shoulder injuries, and for us in pediatrics and especially the orthopedic world, a lot of times that begins with the collarbone. So I think that's probably where we start. Next slide. So we see collarbone fractures all day long. A lot of times those come from just a fall on an outstretched hand. Sometimes people fall directly on the shoulder, and most of the time we're talking fractures in the middle third of the clavicle there. We do see proximal fractures and distal fractures, but I'd say 19 times out of 20, it's right in the middle third there, like the picture shows. In kids, I mean, I've sent maybe one in the past 3 years for anything surgical, but we almost always treat these non-operatively. Things that show up in clinic, obviously, have been screened out for some of those surgical interventions, such as if the bone is coming through the skin, if it's an open fracture, if there's any neurovascular compromise where you're, having persistent numbness, tingling, loss of sensation in the arm. You have a lot of important things with the brachial plexus and some vascular structures right behind the collarbone there. So a lot of those things, if they happen, are going to surgery right away. But most of the things that show up in clinic, especially, are non-operative. Again, if the skin is being under pressure and we call it skin tenting, or that 1.5 centimeter shortening is definitely a relative thing. I wouldn't say that's a definite by the books. You have to operate if it's more than that. Generally, when we're talking younger kids, we're treating these non-operatively every single time, unless, again, it's an open fracture. By the time kids get to skeletal maturity, then we're a little less forgiving with some of those, but we treat people with 1.5 centimeters of shortening, displaced fractures all the time, non-operatively. It just takes a little bit longer, but we're usually talking to the family. Would you trade a bump, which is what you get with non-operatively, versus a scar where you're gonna have somebody go in and put a plate across the fracture there? And often, from talking with my surgical colleagues, that ends up causing some, I would say discomfort down the line. And so often people are going in and removing that piece later. So you're actually looking at 2 surgeries if you treat these operatively. So generally we try to teach people, like, this is fine. You don't necessarily need to operate on this unless, again, you hit those certain things. You can go to the next slide, Michelle. Generally we're putting people in a sling and swath where you're basically immobilizing them relatively. Usually the first 3 to 4 weeks, we see them back at that 1 month mark. Generally, we see enough new bone forming on an x-ray and the patient is in no pain. So as long as they meet those things, we get them out of the sling, we get them moving, but we usually hold them back from sports and contact activities for at least 2 months, sometimes even longer. Again, the younger kids sometimes are better in 6 weeks if we're talking, a 4-year-old, a 5-year-old. But once you get into the teenage years, we're usually looking at least 8 to 12 weeks to get back to contact sports. You know, there's some certain x-ray views. Usually the AP is good, but then there's a Zanka or an axial view, which just has a little tilt there that can give you a good view. And again, if you're looking more at the joints, like the sternoclavicular joint or the acromioclavicular joint, sometimes you may want a little better picture, like a CT scan, if you're worried that there's a little bit more disruption to the joint. Next slide. We see AC joint sprains also, and this is probably something you guys hit on because it's an adult problem as well. A lot of times this happens in the skeletally mature kids a little bit more often because the younger kids just break the clavicle. You know, we classify the AC joint sprains based on what amount of disruption there are of the ligaments, as well as how much displacement there is. Generally, this happens from falling directly on the shoulder, and then there's a crossover test where you basically have the patient put their, you know, if it's their right arm or right shoulder that's injured, you put the right arm over on the left shoulder where you cross across. They're also called a scarf test. That is going to really irritate those kids. So if you have pain over the AC joint and sometimes deformity, then you know, you're often going to have pain with that. You can go to the next slide. Usually we treat these non-operatively also. If you just injure this, you know, type 1, type 2, where there's minimal to no displacement, even a little superior displacement, you know, we treat these non-operatively in a sling. Kind of depends how much pain they're in and how displaced it is, but usually a couple weeks in a sling at most, and then we get them doing early mobilization and physical therapy. Again, if you're having a little bit more displacement, you know, where this is anterior or posterior significantly, or skin tenting, sometimes high-level athletes will have surgery there too, but generally treated non-operatively. Sometimes there's cosmetic deformity, but generally not. And again, if you have questions, you can always get a contralateral view where you look at the other shoulder. That's pretty helpful for a comparison if you're worried, is this displaced, is it not, is this just how their shoulder looks? Next slide. So we see shoulder dislocations all the time, especially athletes who are playing contact sports. Definitely one of the risk factors there, as well as prior dislocations, and sometimes people who are just generally lax in general. They have a lot of motion at the shoulder with regular movements. Generally, this is going to dislocate anteriorly and inferiorly, although you can have a posterior shoulder dislocation. There's two different deformities of the bone that we see with these. One is called a Hill-Sachs deformity, which is kind of a dent or a fracture in the posterior lateral humeral head. You can also have a Bankart injury, which is a fracture of the glenoid, usually inferiorly. We do see axillary nerve injuries about 10% of the time with this, where they lose some sensation and strength of the deltoid and the lateral shoulder there. We see labral tears all the time, which I think I talk about next with these dislocations. And then again, you can have other fractures and rotator cuff tears with these as well. Next slide. The treatment for this, you know, on the field, or if you're around someone who has recently dislocated, you try to get them to relax, to let the muscles go so that you can pop this back into place. A lot of times these go to the ER, and sometimes people need to be sedated to get these back. But often if it happens acutely on the field, we try to put them back in place using a number of different techniques. Usually we'll immobilize them if that happens, you know, in a sling, follow up with orthopedics. We usually, if it happens recently, like within the last 2 weeks, generally we don't need an arthrogram, but often an arthrogram, if this happened a couple weeks ago with the dye injection into the shoulder prior to the MRI, is the best way to look for labral tears. And so we always get an MRI plus or minus the arthrogram on first-time dislocators and often on most dislocations, just to make sure there's not any concurrent damage to the labrum or some of the other structures that may need surgery. You can go to the next slide. If the patient doesn't need surgery, then awesome, we get them doing PT. If they do, it's often because they have a labral tear. So that labrum is I describe it as like a cartilage rim or cartilage bumper that holds the glenohumeral joint in place a little bit better. You can tear that with a lot of different things, but shoulder dislocations are definitely one of the ones we see frequently there. Sometimes people describe a clicking of the shoulder or just pain that's not improving with physical therapy. There's some tests for the labral, labral tears like O'Brien's test or Clunk test. speeds tests, but those are also pretty non-specific, and they can be painful for, biceps tendonitis or a rotator cuff injury or something like that as well. And again, depending on what we see on imaging, often most labral tears are going to get fixed surgically, especially in someone who has an acute labral tear from something like a shoulder dislocation. I'm sure Michelle or some of the people that treat some of the older adults have talked about it otherwise, but I think some of the, just kind of degenerative labral tears don't often need surgery, and you can treat those non-operatively. But in our field, we're generally seeing these things that happen acutely, and so we're usually sending those to our surgeons for repair. Next slide. Multi-directional instability. This is one we see all the time, especially swimmers. Gymnasts and some of those other people, other sports tend to have this as well. But we see this a lot of the time in people who need full range of motion at that shoulder and repetitively. So again, swimmers, gymnasts, we see this commonly in. Basically, the glenohumeral joint just has extra motion there, and some of that is developed, from just those repetitive motions going around, in the kind of ball and socket range of motion. But we see this sometimes people are just a little bit more loose for, collagen disorders or other reasons why they just have extra mobility. The sulcus sign, you can basically put axial traction and pull down on the arm, and if you can see kind of a gap between the basically at the shoulder above the humerus in that glenohumeral joint, you can kind of see a little separation just from a little pressure there. That's called a positive sulcus sign. You can also just basically move the shoulder, the humerus back and forth in the glenohumeral joint in people that are extra loose there. And then you can do apprehension and relocation testing, where you basically abduct and externally rotate the arm, and they get apprehensive that the shoulder is going to pop out of place. Again, a lot of times this happens, you feel instability from after something like a shoulder dislocation, but some people just have this instability, especially in the people that haven't had a recent injury. We're treating this with physical therapy until the cows come home. There's very, very few people that benefit from surgery, and we end up seeing a lot of second opinions from people in the area who do some type of stabilizing procedure to the capsule there, and it often doesn't work. So we end up doing physical therapy a lot. It can be a very frustrating problem for many of the teenagers that come in with this, because it's not a quick fix. You basically have to strengthen the rotator cuff and avoid the positions that are putting them in an unstable position, and essentially hope that that joint capsule tightens down and that the rotator cuff muscles and some of the other stabilizing muscles can do their job just with physical therapy and strengthening, because they just have loose ligaments. Next slide. Rotator cuff strains, see this all the time. Overhead athletes, people who have falls, trauma, we see this all the time. Rotator cuff muscles, I'm sure you guys are well aware, are some of the stabilizing muscles of the shoulder and keep that humerus from sliding around and getting pulled out of the glenohumeral joint. A lot of times we just treat these with rest, NSAIDs, ice. We'll see you back in a couple weeks. Some people come in and they're, super dramatic. Oh my gosh, everything hurts in my shoulder. It sounds like a rotator cuff tear. Let's put some ice on it. Let's rest for a few weeks from your sport. We'll have you come back. A lot of times some of the overwhelming inflammation has calmed down at that time, and they're either all the way better, or we end up saying, okay, it's just the rotator cuff. Now your deltoid doesn't hurt. Now your pec doesn't hurt. Now some of the scapular stabilizing muscles don't hurt. Awesome. This is just a rotator cuff injury. We'll get you guys doing some physical therapy. We'll do some, stretching, strengthening, whatever they need. But in our patient population, I haven't sent any people for surgery of a rotator cuff, tear. If you have a full tear, then, that's a different story, but it's just very uncommon in our population. So we can usually treat these non-operatively, but we do see it all the time, especially in those overhead athletes. This can be often an overuse injury. Next slide. Little league shoulder. All right, so this one's pediatric specific. So people who have open growth plates are more susceptible to overuse injuries and inflammation at the growth plate itself. And we'll touch on this many times, but there are a lot of new cells being created at the growth plate. That is where the bone is growing and getting bigger from. So that is an area that's a little more susceptible to inflammation. So for our overhead athletes, most notably our throwers, baseball, softball, but we do see it in volleyball and tennis as well. We can get overuse injuries where you're basically putting extra stress on that growth plate from a combination of bad mechanics and improper technique, as well as overuse. Imaging may be normal, but we often do see widening at that proximal humerus growth plate. Next slide. Typically, people, especially baseball players, will come in and say, hey, I can't throw as hard, and when I throw, it hurts. Usually, we're resting them, for an initial period. And the way I like to describe it to patients is we have an overuse component and we have a mechanical component. So if we just fix one, the other one is not going to allow this to get better. If we just rest, we haven't fixed the mechanical component. If we just do physical therapy to fix the mechanical component, then we haven't let the inflammation calm down and rested. So we've got to do both together. So generally, depending how bad it is, we'll start them off with just rest for a few weeks. Then we'll rest them from overhead activities and do physical therapy. Or sometimes people have a couple, weeks getting in to see us. Hey, I haven't thrown in 3 weeks, 4 weeks, but it still hurts when I do try to throw. Perfect. All right, we'll get you doing some physical therapy. Let's resist some of those overhead activities in the meantime. We'll see you back in 4 to 6 weeks. At that time, if you have better strength without pain and better range of motion at the shoulder, awesome. We start you doing a throwing program. Or if you're a tennis athlete or a volleyball player or something, we'll get you doing some sport-specific techniques to get you back, doing that in a slow, gradual progression. Importantly for us, we talk about prevention, because if we send a 12-year-old back out and, hey, we did physical therapy and we rested and I feel better, well, we've got to make sure we continue doing some of those home exercises. We've got to make sure we're sticking to pitch counts. We've got to make sure we're not throwing curveballs at too young of an age, or we're not putting excessive spin on the ball or throwing sidearm or doing some of those things that's going to just cause this to come back. It's frustrating for us, and definitely more frustrating for the patient when they come back the next year and the same thing has happened. So we definitely encourage them to get in a good habit so that we can prevent these injuries from occurring in the future. Next slide. Perfect. We'll go on to elbow. Next slide. We see many elbow injuries. Very, very common injury that we see are supracondylar humerus fractures. That and radial neck fractures of the elbow we see all the time in kids, usually under age 10. It can be older, but supracondylar fractures are definitely pretty specific for pediatric people. Fall on an outstretched hand, sometimes just falling on the elbow. Generally, for those type 1 and some of the type 2 injuries, we can just cast them for 3 weeks and then start moving. Usually 4 to 6 weeks, they're back to normal. For the type 3 injuries where there's a full, displacement or translation or a big angle of that fracture, we often take those to surgery to put a pin in it. Also, obviously, neurovascular compromise or open fractures, we have to do that as well. Next slide. Little League elbow, very similar to Little League shoulder, but instead of the growth plate at the proximal humerus getting inflamed and injured, we're talking about the medial epicondyle. This is a valgus stress injury, and in kids, instead of injuring the UCL, which we also do see, often these kids will injure the medial epicondyle. Sometimes on x-ray, we do see widening of that, but again, many times the x-rays are normal. The patients are just tender over that medial part of the elbow, and they describe pain with throwing. Again, an overuse injury in combination with bad mechanics. And then sometimes we do see, again, medial epicondyle fractures. Next slide. We, on physical exam, see this tenderness over that medial epicondyle. They have pain with valgus stress. There's a maneuver I love called the milking maneuver, where you essentially put their arm in abduction and external rotation, and then you kind of pull on their thumb as you take their arm through kind of a range of motion posteriorly, and that almost always elicits pain. You can also get contralateral x-rays from the other side just to compare to see, hey, is that growth plate widened or does that look normal? Generally, we're a little bit more aggressive on surgery for these, but still almost never happens. You have to have a pretty wide displacement of a medial epicondyle fracture there. but generally we're going to cast somebody if this is a fracture. If this is an overuse injury, we're going to just have them rest, just like the shoulder, for a couple weeks, start them in physical therapy. Not only are we working on flexibility and strengthening of the muscles around the elbow, we're also focusing on the shoulder there. So we're looking at the rotator cuff muscles, we're looking at some of the scapular stabilizing muscles, we're looking at, how much are you throwing with your lower body? Do you have core weakness that's leading to this? So in physical therapy, we're looking at a lot of that to evaluate their mechanics. Then when they come back, hey, we're feeling better, haven't thrown, everything on exam is back to normal, great. We'll get you started on a throwing program where we gradually increase how much you throw and how hard you throw over the next couple weeks. Again, prevention, extremely important. Next slide. All right, osteochondritis dissecans. This is definitely a pediatric specific problem where essentially we have a overuse injury and small micro traumas that are causing a portion of the bone to get a poor blood supply. And what can happen is the bone, you can see in the capitellum there's kind of a lucency, and the patients can have that piece of bone, if it fully loses its blood supply, the cartilage can get disrupted and some of the joint fluid can actually get behind the dying bone right there. Now, if this goes kind of untreated and worsens, that piece of bone can actually fracture off and become like a loose body in the joint. Now, we see this commonly in the capitellum of people who put a lot of weight on their arms. So we see this a lot of the time in gymnasts and sometimes in throwers. Now, throwers aren't necessarily putting a lot of weight on their arms, but they are having repetitive motion where there's pressure on that part of the bone. Next slide. Sorry, next. There you go. So, often people come in, hey, I have pain on the outside of my elbow. Sometimes if it's progressed, they'll describe locking, or they don't have lack of extension, or they're losing some extension. X-rays, often you can see this, but sometimes you cannot. We always get an MRI to evaluate how much disease progression there has been. Now, there's a couple different stages of this. Stage 1 being the mildest, stage 4 being the most advanced, where there's actually a loose body that has broken off. Stage 1 injuries there, we're usually talking about just activity restriction. Sometimes we'll immobilize and we follow those. We don't always shut people down from sports, but often we do, and just kind of follow along and look for healing there. Usually stage 2, 3, and 4, we're often referring to our surgeons here, not always for surgery in stage 2, but some of our surgeons are fairly aggressive, because what they have seen is if that blood supply is not restored to the piece of bone that's not getting enough vascular supply, then that piece of bone can progress, and the surgery, as it gets to stage 3 and stage 4, is much more difficult, and the chances of success are much worse. Whereas people who come in and have a little bit of fluid behind the piece of bone there, but not necessarily any subchondral cysts or any instability of the cartilage, they can do a small procedure just to kind of revascularize that piece of bone, and the patient often does very well. Next slide. Painter's disease is generally seen in younger kids. So while OCD lesions are often seen in kids like 10, 11, 12, 13, 14, Painter's disease is definitely a younger kid problem, generally between 5 and 12, often less than 10. So again, we see an irregularity at the capitellum there. This is often thought to be just from, again, repetitive microtrauma, but it's also thought to just occur in some kids, and we don't necessarily have a reason for it. For these kids with Painter's disease, and again, if you have questions, you can look at it on an MRI, but this is almost like an irregularity of the growth plate. These kids never need any surgery or anything done. This is self-limiting, non-operative. If you have questions from an X-ray, we'll get an MRI, but generally we're distinguishing these based on age and history as well. Next slide. Wrist injuries, keep going. We see distal radius fractures all the time, and that's definitely the most common thing we see at the wrist sprains all the time. I think I'll talk about those in a second, but some of the unique ones for what we see are Montasia fractures. So what happens there is you have a ulna fracture with a radial head dislocation. So if you have a big ulna fracture, you definitely want to check out the elbow. Make sure that the patient doesn't have pain at the elbow. If they do, or even if they don't, you often want to consider getting a x-ray of the elbow, because sometimes that radial head can dislocate. Now that is definitely a medical legal problem if you don't pick up on that, and it's definitely a surgical problem if you pick up on that. So that is something needs to be sent to the surgeons right away. Usually they try to get to that in less than 2 weeks, less than 1 if possible. But if you have an isolated ulna shaft fracture that's more than just a little green stick fracture, you always want to check out the elbow, make sure they have good range of motion and nothing wrong there, because that radial head dislocation is a big problem. Now, Galeazzi fractures is a radial fracture with a distal ulna or DRUJ dislocation. Often we'll just push on this back in clinic and relocate it. That is a little less common than the Montasia, but still both of these are fairly rare. This is again more important to look at if you aren't necessarily getting wrist x-rays or forearm x-rays and you can't see that joint. Hey, let's check it out, make sure the wrist doesn't hurt and we don't have something else going on also. Next slide. Torus fractures or buckle fractures, again, the most common thing we see at the wrist there, especially when we're talking fractures. Basically, we're making sure they have proper alignment. Sometimes we mold the cast or push on this a little bit to improve that alignment. Generally, we'll treat this 3 to 4 weeks in a cast, take the cast off, get an x-ray, we'll put them in a wrist splint for a couple weeks. We get an x-ray at that mark, make sure they don't have pain, make sure that we see some callus formation around there. This is usually healed in 4 to 6 weeks. Next slide. Scaphoid fractures. All right, awesome. This is definitely something that it sometimes gets missed, but fall on an outstretched hand, pain at the wrist. Hey, I don't see anything that's wrong with the radius or the ulna, but they have pain in that anatomic snuff box. This is something that often gets missed by the patient themselves, because sometimes they, it's just like a skateboarder or somebody that comes in, 6 months later and, hey, I fell and this dull ache just never went away. This scaphoid fracture the scaphoid bone has a poor blood supply. And if this is not picked up on and immobilized, that runs a higher risk of non-union, which definitely can lead you to, problems down the road at the wrist joint, as well as just continued pain. Generally, fractures in the mid body of the scaphoid do all right. Fractures distally in the scaphoid do well. Fractures proximally in the scaphoid do less well. So you can kind of go based on that as to how high of a risk this is. But as long as that scaphoid fracture is non-displaced, we're generally treating this in a thumb spica cast for at least 6 weeks. And then we're evaluating at that time, making sure we have enough callus formation, sometimes confirming with a CT scan if we don't see that, to make sure that this is healing like it should. Otherwise, this is going to the hand surgeon for a potential screw. Next slide. Gymnast wrist. All right, awesome. This is an overuse injury of the distal radius, similar to what we see with the Little League shoulder, Little League elbow. However, this is almost exclusively seen in gymnasts or people who put they're overusing their wrist by putting axial loads on that wrist. What we're seeing on x-rays often are normal, but we sometimes see widening of that physis of the distal radius, and sometimes we have an increased slope of that epiphysis as well. Generally for this, we're talking rest for the first couple weeks, range of motion exercises if they're not in a cast. If we see radiographic changes, we're always putting them in a cast for a month. But sometimes people come in, hey, I'm a gymnast, my wrist hurts, they hurt over the distal radius, x-rays are normal. All right, we can just do some rest and range of motion exercises, maybe a splint, and they can go back to sports a little bit sooner. Again, if we see radiographic changes, we're definitely resting the first month. Then that second month, we're working on range of motion and strength. We're doing some conditioning, often with physical therapy. And again, just like the shoulder and the elbow, we not only want to heal the bone with rest, but we want to change the mechanics so that hopefully this doesn't happen as they go back to their weight-bearing exercises in gymnastics again. After that 2-month mark, as long as they're feeling good, x-rays are showing healing, perfect, we'll get you back starting some gymnastics again. Next slide. Wrist sprains, I won't go into detail there. Tons of tendons, some ligaments around the wrist. someone has a fall doesn't necessarily mean they have to break something. Often we're treating this in a wrist splint. We're giving them ice, ibuprofen, go back to activities when you're feeling better. Next slide. All right, let's go to lower extremities. So the hips next. One of the big peds ones, I'm sure you guys have heard of this, if not seen it, but SCFE, so slipped capital femoral epiphysis. What happens here is essentially in kids who are skeletally immature, that epiphysis of the proximal femur looks like an ice cream cone sitting on, or a scoop of ice cream sitting on an ice cream cone. On the right side of the screen there, you can see that that ice cream has slipped off the cone. So what can happen there is the blood supply can get disrupted. Obviously, if you have, this is essentially like a fracture. If the blood supply to that epiphysis is disrupted, then it's not going to do very well and it's not going to heal the right way potentially. So we see this commonly in kids who are overweight and in kids who are like 10 to 14, 11 to 13. I've seen, I've been in clinic here for like 3.5 years. We see generally like 5,000 patients a year. I've probably seen 3 or 4 of these. So not super common, but the ones that I have seen have all been subacute. People come in, they have a year of hip pain or something like that. Sometimes they're even bilateral. Kids are presenting with a limp, they're presenting with groin pain, they're limited on their internal rotation and their legs are kind of held in external rotation. This is immediate non-weight bearing, send to surgery, send to ortho, and they're putting a pin in this and they're reducing this. Often, if that triradiate cartilage is open on the other side or on that side, they're often pinning the other side as a prophylactic thing so that the other side does not have that problem. The longer that essentially SCFE is present, the worse the outcome is for the patient. Next slide. Similar, board type question here, but generally a little bit younger, is called leg calf Perthes disease, or Perthes disease as it's shortened to. What we see here is an avascular necrosis of that proximal femoral epiphysis. So this is generally, again, in kids less than 10, males much more common than females, and the blood supply to that femoral head is interrupted. Generally, this is self-limiting, which is really hard to tell the families because it's hard to say when that will happen. They come in with pain and limping, but it's hard to say, is this going to get better in a few months? Is it going to take a few years? Sometimes people with Perthes disease end up having kind of long-term chronic changes to that femoral head, which can obviously lead to pain and trouble at that femoral acetabular joint in the future. Sometimes x-rays are normal early and we'll see this on an MRI if we end up getting one, or we're just kind of following them along. Hey, this might be Perthes disease. Let's repeat an x-ray in a couple months. Usually we'll try to restrict their weight bearing and treat this non-operatively in the beginning. And very, very rarely have I ever seen any of our guys operate on something like this. Again, because that femoral head hasn't necessarily slipped off. It just kind of has a poor blood supply, which is usually self-limiting if we're able to restrict the weight bearing there. Next slide. What we do see a lot, and I'm sure you guys have talked about this in the past, is femoral acetabular impingement syndromes. So what you can have here is there's extra contact between the femur and the acetabulum at the hip. Now, if this goes on and on and on, it can lead to damage of the cartilage. It can damage the labrum. And so generally, we're trying to do a couple things to increase their range of motion and make sure that we don't damage those things in the long run. So a cam type lesion is what we call it when there's extra bone on the femoral neck. So we'll go on to, you'll see a visual of this on the next slide, but the femoral neck has kind of an extra bump. So you end up getting limited internal rotation, limited hip flexion, some pain, and you may even notice compared to the other side, there's a little less range of motion. Now, a pincer type deformity has extra bone on the acetabular side. And for both of these, we're usually starting with activity modification, physical therapy, rarely surgery, but we do usually start non-operatively on something like this. People can have combined types, and you can go to the next slide, Michelle, where there's a visual of this. People can have cam and pincer deformities, but you can see on the cam lesions, generally there's some overgrowth on the femoral head and neck, generally pincer, there's a little overgrowth on the acetabulum, and then combined people are just unfortunate where there's extra bone both ways. And you can imagine as the hip internally rotates and usually goes into like flexion, those bones are going to hit against each other, and it's going to limit people in their range of motion. So a lot of times dancers come in and say, hey, I can't do the moves that I want to do. And then we get an x-ray and, hey, this is why. It's not just you and your flexibility, it's because you have, a bone that's getting in the way. So often physical therapy will treat this with initially. You can have labral tears, you can have problems there where we do send this to the surgeon for evaluation of the labrum or to kind of take down that cam deformity or pincer deformity. Next slide. Snapping hip, we see all the time. There's two different types, and a lot of times people come in and say, hey, my hip is dislocating or it's popping a lot. Internal snapping hip, we're generally talking about the hip flexor tendons are snapping as the bone comes across the anterior part of the pelvis, where we're talking either over the acetabulum itself, over the femoral head. People are describing this medially, anteriorly in the groin, whereas external snapping hip, we're often talking about the IT band and the TFL kind of snapping over the greater trochanter there. Now, both of these are generally things we treat with PT, stretching, anti-inflammatories. That's usually the treatment. Very rarely do we do anything else for those, although you can do injections, I believe, but very rarely do we ever get to that point in our population. Next slide. Muscle strains, we see this all the time. Hip flexors, adductors, quad, hamstring. Oh my gosh, we see this all day long in soccer players, football players, you name it, people are coming in with muscle strains. Generally, depending on how bad it seems, sometimes people come in, they're barely limping. All right, maybe a grade 1. We'll get you doing some rest, ice, followed by physical therapy, get you back to sports in a couple weeks. Sometimes we see people coming in with a big limp. They have palpable, defect in the muscle there. And, for those, we're a little bit less aggressive. And so we'll start with, again, ice, limited range of motion in the beginning, get you doing some physical therapy. We're usually talking return to sports, sometimes 4, 6, 8 weeks for those, rather than, getting you back in 2 to 4 weeks for some of the mild ones. Now, the one thing we do see, and we get x-rays all the time because I work in an orthopedic department, so that's kind of the norm, but you got to worry about avulsion fractures for pediatric patients are much more common. So we're looking, at the ischium for some of those hamstring injuries and some of the, adductor injuries. We're looking at the ASIS and the AIIS for some of the hip flexor injuries. So always got to be careful. An avulsion fracture is going to heal very well because bones have great blood supply. However, they are going to take a little bit longer. So generally, we're getting people back to sports in about 2 months for an avulsion fracture, whereas a simple muscle injury can range anywhere, again, from 2 weeks, 6 weeks. It kind of depends on the grade. Next. Oh, perfect. All right. So I have some anatomy there. There's obviously a ton of muscles that we see there. A lesser trochanter fracture, we actually see that as well. But a lot of times you're looking at the AIIS, ASIS, and again, along that ischium, you have a lot of muscles that attach as well. Next slide. Transient synovitis. This is one we see in kids all the time. Generally, the little kids, 18 months, as young as that, but often ages 2 to 8. You get inflammation and some hypertrophy of the synovial lining, which is a self-limiting thing. We often see this in the hip, but it can be any joint, so we often see the knee as well. Often we'll have some type of history of a viral infection from the family or a concurrent viral infection, but about 20% of the time is what research has shown that there is nothing that the family can pinpoint any recent illness. Generally, things are improving on their own in about a week or 2, and we treat this with Motrin, close follow-up, usually come back in a week, make sure that these little kids that are limping aren't getting worse. Sometimes you can get an ultrasound of the hip if you're concerned about something like that. Generally, these kids aren't sick. They're not coming in with fever. They're not coming in with refusal to bear weight. Those are things where we're thinking, all right, maybe there's an actual joint infection. Next slide. Knee injuries. All right, next. ACL injuries. I won't spend a ton of time on this because I'm sure you've had a ton of talks about this, but main stabilizer of the knee, preventing anterior translation of the tibia. There's 2 bundles. A lot of times this is a non-contact injury. Risk factors are being female, playing on turf, contact sports. Next slide. You often see an effusion when people come in. Positive Lockman exam is my favorite, most sensitive and specific. You can do anterior drawer testing, especially in some of your big athletes that it's hard to get a good grip on their leg. Pivot shift test is one of the ones the surgeons like a lot, but it's hard to get the kids to relax. The important thing too is, we're always getting an MRI to confirm this, but you're also looking for concurrent injuries to the meniscus, PCL, MCL, tibial plateau fractures, tibial spine fractures, a lot of those kind of things. Next slide. Generally, we're, again, looking on x-ray, we're getting MRIs, and this is always going to the surgeons. Now, depending on if the kid is skeletally immature, we do a lot of different reconstructions here. So sometimes you can do IT band for kids who still have open growth plates, but a lot of times our surgeons are doing patellar tendons, quad tendons, hamstrings, and then again, we're talking, many months of good rehab. So our surgeons always say, the surgeon is important, but the physical therapist and the athletic trainers and people doing the treatment afterwards are even more important. So you can have a great surgeon and a great surgery, but if you don't do good rehab, you're not going to get better. So next slide. And then on the right there, you can see that's an ACL tear compared to that nice firm black line on the left of what a normal ACL would look like on a T1. Next. Think we'll touch on, some of the other important ligaments there. So PCL is providing stability against posterior translation, kind of that textbook dashboard injury where you're in a car accident, your knee hits against the dashboard. Often doesn't require surgery. MCL injuries is on the medial side of the bone and the knee. LCL, the lateral collateral ligament, is on the lateral side. And then a lot of times, depending on how bad that injury is, we're often not treating those surgically, but often we do see that concurrently with ACLs and meniscus and things that do need surgery. So depending on how bad it is, those often do get fixed with surgery if they need to. Next slide. Meniscus injuries. All right, so this is cartilage structure, sits in the knee, provides you some shock absorption between the femur and the tibia. The outside of that is vascularized a little bit better and heals better than the central portion where you're getting close to like the tibial spine. Almost always we're treating this surgery because we're not seeing degenerative tears. Whereas Michelle and some of the people treating adults, in an 80-year-old, you're often seeing degenerative tears there. Those often you don't want to treat surgically as, first line, depending on how it looks. But we're often seeing this as like, hey, I had an injury last week, boom, now I've got a big swollen knee and I can't walk. Again, people describe swelling and pain, catching, locking, clicking, those kind of things with meniscus tears. Next slide. You'll have positive McMurray exam. There's the Thessaly exam, Apley compression test. Sometimes people describe locking there, especially if they have a bucket handle tear or a loose body of that meniscus. Again, you want to rule out other injuries, so you're getting an MRI if you're concerned about a meniscus tear at our age. And then we, very rarely are treating these spontaneously with like physical therapy. Sometimes we do, depending on the type of tear it looks like, and whether, sometimes in kids we see what's called questionable tears where there's just extra vascular, signal seen in the meniscus, often the posterior horn. Some of those, hey, it kind of correlates with where your pain is, but let's observe this. Let's do physical therapy and rest. If it gets better, great. We avoid surgery. Otherwise, we're sending this to surgery. Next slide. Patellar dislocations, we see this all the time. This is almost always a lateral dislocation. Sometimes it's a non-contact injury, but sometimes it is a contact. Hey, I fell directly on the knee. You can tear or stretch that MPFL, but if that's the only injury, we don't necessarily do much about that surgically initially, unless they have recurrent injuries. But first-time dislocators for sure, as long as they have an effusion there and it sounds like this was a true patellar dislocation, we're generally getting MRIs to look for any osteochondral injury. Next slide. If we do see, damage to the cartilage or a loose body there, we're often sending this to surgery. But on the MRI, we're also looking at the TT to TG ratio and looking at the for trochlear dysplasia to see, what's this patient's risk factor for having a recurrent problems there. On physical exam, you can look at the Q angle, you can palpate, see where they have pain. A lot of times they'll have kind of a J sign if they have some patellar maltracking. Patellar grind test may show some crepitus. But an acute patellar dislocation, we're usually getting an MRI and treating them either physical therapy and a knee brace to stabilize the knee in the interim, or we're sending to surgery to reconstruct the ligaments, remove that osteochondral fragment, replace the osteochondral fragment, and sometimes move that tibial tubercle if they do have a high TT to TG ratio. Next slide. Generally, we're looking for a patellar dislocation of getting kids back to sports. If they don't need surgery in about 6 weeks is usually the goal, sometimes sooner, but not always. Now, some of the osteochondroses, so that's a fancy word for saying inflammation of a growth plate. We'll hit a little bit of this on the foot and ankle as well, but in the knee, we're talking Osgood-Schlatter, Sinding-Larsen-Johansson syndrome. Osgood-Schlatter is over the tibial tubercle. Sinding-Larsen-Johansson is over the inferior pole of the patella. A lot of times kids come in without an injury. They just say, hey, it hurts when I run or play basketball, or, a lot of times this is a, jumper's knee, quote unquote. This gets better, ice, stretching, resting sometimes, but activity modification. We're often talking about patellar sleeve, or a knee sleeve, or for Osgood-Schlatter, a patellar tendon strap has been shown to help with that as well. Again, there's just inflammation from overuse at that growth plate, just tendons pulling on the open growth plates there causes inflammation. Next. We do see OCD lesions of the knee as well, and that's generally the lateral aspect of the medial femoral condyle. We see the knee ones a little more common than the elbow, and then we'll get to one in the ankle as well. But again, this is more common in the legs because people are putting weight on their legs. Everybody, not everyone is putting a lot of pressure on their arms, but we see this in the knee. Again, it kind of depends on how advanced of a stage this is. That one on the right is stage 4. That's a big displaced fragment there, whereas the one on the left still looks a little unstable, but is maybe something that we don't necessarily have to remove that fragment or surgically put it back. We can kind of do a procedure to regain blood supply there. Next. Again, we're going to grade that based on MRI, so you can read through kind of that. We're looking at the cartilage, we're looking at signal behind that fragment in the bone, and again, if you get farther along, we're talking about this loose body has totally detached from the rest of the bone. So treatment, again, grade 1, we're often observing it. Grade 2, some grade 3s, we're sometimes just drilling through that fragment with small microfractures to help regain blood supply there. And then sometimes we're often, putting a screw in there to hold it in place, or actually removing that in general if it's fully pretty advanced. Next slide. Proximal tibia fractures we see all the time in younger kids, generally ages 3 to 6. There is what's called a Cozen phenomenon, which can happen where you get a late valgus deformity after an injury like this. I saw a kid today who had a proximal tibia fracture that we're going to follow up every couple months to make sure they don't develop this. Essentially, the bone looks fine initially, but it over time kind of develops this valgus deformity, generally self-limiting, and it actually corrects as you grow, but sometimes it does require surgery if it gets more than 15 degrees. Sometimes we'll put the cast in a certain varus mold to prevent this from happening in risky fractures. Next slide. Tibial stress fractures we see all the time. I'm sure you guys see that too. We got dreaded black lines. These are pictures I took from clinic. We see this in overuse injuries all the time. I sent this one to an orthopedic, one of our surgeons, to consider having a nail put down that, but generally we're trying to treat that non-operatively with physical therapy and rest until they're better. Usually they're not this advanced also though. Next slide. Toddler's fractures. All right, so this is another tibial fracture. Generally, tibia, you think of big, thick bone, hard to break. Well, there's oblique fractures or spiral fractures that occur in toddlers with just the right amount of force, and it's kind of a twisting mechanism as well as a fall on it. Often kids will go down a slide and kind of get their leg caught under them or behind them. Boom, toddler's fracture. Often the kids come in, they're little, they don't talk, they say, or the parent says, hey, they're not putting weight on it, you get an x-ray. Sometimes you see what you see there, where you have a very subtle fracture at the distal tibial metaphysis, and sometimes you don't see anything at all, but they're very tender and they won't put weight on it. We'll often put them in a cast and then reevaluate in a few weeks. Next slide. Cuboid bone, again, is sometimes called toddler's fracture as well, where the toddlers often break that. Often we'll start with a non-weight bearing cast for a couple weeks in these kids, and then we'll follow it up with a short leg weight bearing cast. Sometimes if it's truly non-displaced and very distal in the tibia, we let them start walking on it right away if it's non-displaced. But every fracture is a little different, so we'll kind of evaluate that on a case-by-case basis. But we want to look out for, it's a tibia fracture, so look for compartment syndrome, very uncommon at this age. But if the injury does go into the growth plate, you want to make sure that that doesn't cause any growth plate arrests as they grow. Next slide. Other common ankle injuries next that we see are ankle sprains. See them all the time. Pain over the ATFL, tibiofibular ligament, deltoid ligament. Depending on how bad they hurt and if they can walk, we're often talking about immobilization initially versus a lace-up ankle brace, getting back to sports. Some of the mild ones, we get them back within a week or two. Some of the more severe ones, we're immobilizing, we're doing PT, we're getting them back, 4 to 6 weeks. Next slide. Physical exam, for ankle fractures, kind of pain more over the ligament. There's a Ottawa classification system where, pain over the bone, we're getting x-rays, pain over the ligament, you don't necessarily have to. Making sure anterior drawer test, they don't have any instability there also. So high ankle sprains, you're concerned about a syndesmotic injury, and those we're a little more careful with, and you want to make sure they don't have widening of that syndesmosis with weight-bearing x-rays. Next slide. Okay, there's the Ottawa ankle rules. You don't have to read those now, you can look those up. Next slide. And sorry, we got a lot of ankle sprain stuff here. So again, initially we're treating this rest, ice, compression, elevation to help with that. And then we're kind of getting you back to sports. And again, depending on the kid, what their pain tolerance is and how bad it is, you can run through phases 1 to 3 within a few days. Sometimes we take a couple weeks for those also, depending on the kid. Next slide. Got some ankle fractures in here somewhere. Yeah, so distal fibula, we see those all the time. Again, only 10% of the weight goes through the distal fibula, so often kids are able to walk with a distal fibula fracture. We usually put those in a cast for 3 to 4 weeks and then get them back to sports in 6 to 8 weeks. Distal tibia fractures, we're generally starting with non-weight bearing for a couple weeks because we don't necessarily want to risk that as most of the weight does go through the tibia. Some of those I've seen take as long as like 5 months to get back to sports. And some of those, depending on the age of the patient and how displaced they are, we're usually talking 2 to 3 months. Talow and triplane fractures are common things, and those are pediatric specific. So let's go to the next slide. A Talow fracture is a fracture through, it's like a Salter 3 fracture, where it goes through the epiphysis and out the growth plate there. Whereas a triplane fracture is a Salter 4 fracture, goes through the epiphysis into the joint, but it also extends above the growth plate as well. Next slide. These are very risky. Oh, I'm sorry, previous slide. These are very risky for having growth arrest. So we're very careful with these. We make sure there's very minimal displacement. Those are often non-weight bearing for 6 weeks, best case scenario. Then we get you into a weight bearing cast for about a month. Then we start doing PT, get your ankle strength and range of motion back. A lot of these are going to surgery if they do have any displacement at all. And when I say any displacement, we're talking like 2 millimeters or more. We're not very lenient on these. This is generally seen in kids who have closing growth plates. So we don't see this in like 7-year-olds. We see these in kids who are, 13, 14. Next slide. I know it's 7, I'm almost done. I got a couple slides left. Achilles tendon ruptures, we do see adult injuries. That was an Achilles tendon rupture that I saw. We sent that one for surgery. Next slide. Oh yeah, this one went to ortho. Next. Seaver's disease and calcaneal apophysitis. This is another osteochondrosis, just like Osgood-Schlatter and Sinding-Larsen-Johansson syndrome. This one's at the growth plate of the heel. We see this all the time, like 3 to 4 kids a day are coming in with this. Often recent growth spurt, tight calf muscles, tight Achilles, high activity levels are risk factors for this, more common in boys than girls. Generally, we're doing some stretching, ice, ibuprofen. Sometimes heel cups are helpful for that as well. I think I talked about that on the next slide. There we go. Perfect. This is generally self-limiting. You don't often have to shut the kids down from sports for something like this. Next. OCD lesions, we do see those of the talus. That looks similar to the ones of the knee and the elbow. Defect in the articular cartilage and subchondral bone, we usually confirm this on X-ray. In the ankle, we're much more aggressive in fixing these from what I've seen and from what our surgeons do. But we're usually restricting weight bearing on these if we see this in the talus. Next slide. Other foot conditions, we do see Iceland's disease, which is painful inflammation of the apophysis of the base of the fifth metatarsal. So a lot of times people come in and they get called a fracture at an urgent care or something. Hey, I was running one day, I've had pain for months. I went to an urgent care, they see an irregular spot on this bone. Well, that's actually just a growth plate. It's not separated or anything like that. Iceland's disease is a injury that we see from, just kind of an overuse injury. You can fracture that bone as well, but generally people have a history that's more supportive of a fracture than just overuse. Kohler's disease is avascular necrosis of that navicular bone, and you can see on the left compared to the right there, that navicular bone is white, sclerotic, and generally painful. Usually casting can shorten the duration of this. I'm sorry about the format of that. That was one thing I must have fixed between last PowerPoint and the one I sent you guys. But generally, casting can shorten the duration of this, but this is a self-limiting condition of that navicular bone. That blood supply just regenerates on its own. Next slide. Tarsal coalition, we see a lot of congenital stuff in peds sports and ortho. So we're looking there for limited range of motion. Some of those tarsal bones have just fused, and sometimes that's a bony fusion, and sometimes that is one that is a fibrous coalition. And so generally, I saw one today actually where you have limited subtalar motion. Sometimes you can see this with limited dorsiflexion or plantarflexion. And it's often easier to pick up when they have a normal range of motion on the other ankle. And so that's easier. Okay, this one is much more limited, not an injury, not swollen. All right, we're concerned about tarsal coalition. Initially you wouldn't think this makes sense, but we often treat this with casting, even though they already have stiffness and range, pain initially. Casting actually works at about 50% of the time to decrease the inflammation, and we don't often need to send these for surgery. Sometimes we'll send these to physical therapy, and then often if things aren't getting better with casting or therapy, we'll send these to surgery to, again, resect the bones that are fused together that shouldn't be. Often kids come in with flat feet also. Painful flat foot, be worried about something like this. Next slide. I think we're going to back. Yeah, perfect. We can run through a couple back things real fast. So spondylolysis, you're thinking spondy. You're looking at a pars injury of the vertebrae, hyperextension, athletes, so gymnasts, football linemen, cheerleaders, dancers, pain with hyperextension on exam. You can sometimes see these on oblique X-rays of the lumbar spine, but you're often considering getting an MRI, bone scan, CT. We usually MRI them just to limit the radiation in our clinic, but generally this includes rest, physical therapy. Sometimes we'll put them in a brace if it's an acute spondy. We'll usually brace these for about a month, and then we get them doing physical therapy from there. Generally, we're talking 3 to 4 months to get back to sports. Minimum, sometimes a little less than 3 months, but we've seen these last 6 months too. So that's a frustrating problem. Next slide. Spondylolisthesis, I believe, is next. Yeah, so that's where you have a bilateral pars defect, and you actually have some anterior translation, usually of the like that one's L4 on top of L5. But most of these don't need surgery, but you do want to follow up on these to make sure things aren't progressing. Generally grade 1, sometimes grade 2, we don't need to do anything about, but especially if we see progression, or grade 2, which is generally like 25 to 50% slippage, we're sending these to consult at least with one of our spine guys, because we don't want to make that worse. Obviously, we got a spinal cord there. We don't want to have any disruption of that or any nerve injury. Next. And then back pain and strain, again, we see this all the time, much more common than those bone problems, but we're treating these usually with heat or ice, and then we're doing some stretching, strengthening, and we're doing some physical therapy for that as well, anti-inflammatory. So I think that's my last slide. Sorry I went a couple minutes over. I'd like to take any questions if you do have any on any of that stuff, or some other stuff that maybe was on your mind that I didn't touch on.
All right, so I'm back, and I'll give them a moment to answer those questions. Sydney did have a good relevant question. The last month's statements of credit are going to be updated to the website tomorrow. So if you were going on and registering and trying to figure out where your statement of credit is, just know that if you check back tomorrow, those will be available. We'll give them another minute or two. It was a great talk, though.
Thanks. I'm sorry I run through things fast. We see a lot of things that probably are overlapping with some of the things you guys see. But you know, ACL injuries, meniscus, shoulder dislocations, they're all important things. So I think it's good to hit on them. And again, some of the stuff that's more of like adult problems we sometimes see in clinic, and I'm sure you guys see plenty of pediatric concerns. So especially if you guys are athletic trainers, you're seeing a lot of this when you're taking care of you know, some of your adolescent athletes. So hopefully some of that stuff on like Osgood-Schlatter and Sever's disease and stuff is helpful, and you can just provide reassurance. We do a lot of reassuring and non-operative treatment in pediatrics. But it is nice to kind of touch on some of the bone injuries too, because we do see a lot more of those than at least I recall during fellowship, just because we're a peds practice and kids break bones all the time.
Okay, Craig has a question, and he wants to know about proximal clavicle head fractures, and then particularly if they have any type of subluxation associated.
Yes. That's a great question. Generally for those, you know, the most important thing is they don't have a posterior dislocation, because especially on the left, you know, you're worried you got a lot of important vascular structures behind it. So generally that's a big problem. That needs to go, like if you notice that on the field or something, that needs to go to the ER right away. I think you're actually supposed to reduce that, like if you can on the field with like clamps and stuff. I haven't seen that, but I think that's what you're supposed to do, especially if there's any neurovascular compromise. But in clinic, you know, we sometimes, it's not super common, but we do sometimes see those fractures. We sometimes will get CT scans if we're concerned about where that is subluxing, or sometimes you can do like a dynamic ultrasound if you have somebody that can do that. We definitely want to make sure that that is coming anteriorly, or, you know, not going back, because that's, again, putting your vascular structures at risk, and airway and stuff. But generally we're treating that, we're treating fractures the same way with immobilization. If it's posterior, you know, you're making sure that they don't have any problems that need surgery right away, but then you're treating it the same way with just, you know, the sling and then early range of motion and stuff. But a lot of times what we see more commonly than that, at least, is subluxation at that SC joint. And so generally for that can be frustrating. So a lot of times we do immobilize, because if you continue to sublux there, then the articular cartilage gets stretched a little bit. And so by, you know, if you have somebody that can just party trick, pop that in and out of place, you know, you're stretching the cartilage, and it's going to take longer to come back to normal and hold that bone in place. So generally we'll immobilize if they're doing that. If not, then we're often talking about range of motion exercises, physical therapy, those kind of treatments. I haven't sent anyone for any more than that. I think you can do injections for those potentially, but generally we're talking either immobilization, making sure they don't have any, like, you know, vascular or neurovascular compromise. And then generally if things are anterior displaced, all right, they may have a bump and cosmetic issue, but not necessarily something dangerous.
And then Craig has a follow-up question. Within those different pathologies that you described, what would be your time frame for returning to contact sports?
Yeah, good question. I would probably, depending on if this is just a subluxation and and it's popping forward and it's not causing any, discomfort, it's just like doing that. They don't necessarily have to stop sports, but if they're getting aggravated from it and it's causing pain and you're immobilizing them, usually I would treat that similar to like a fracture where you'd say, okay, let's immobilize for a month. Let's do physical therapy to make sure we can return to movements without pain. We're usually talking, again, depending on the patient, maybe a month. They don't necessarily have to be fully, avoiding sports if this is subluxing and not a fracture. But generally with fractures, we're talking for collarbone injuries at least 2 months before they're returning to contact sports. And if there's displacement, there's more new bone and new callus that needs to form. So before they're returning to football, rugby, hockey, some of those high contact sports, we're usually looking closer to like 3 months or sometimes even more. If it's non-displaced, then we're usually talking like 2 months is often a more appropriate time. But it depends how much displacement there is and how much new bone needs to be formed, because a lot of times, a 17-year-old isn't going to heal as quick as an 11-year-old. So it kind of depends on x-rays, pain, and that kind of stuff as well.
Awesome. Well, great. Well, thank you so much for sharing your wisdom and sharing your time with us tonight. So thank you so much for that. And thank you to everyone for attending.
Thank you everyone for listening. Thanks for inviting me, Michelle. And my email, if anyone, Michelle probably has it, but it's mdressing@nhs.net, or my other one, just michael.dressing@gmail.com. If you guys have questions or anything else that we didn't touch on, happy to email any of those or just send it to Michelle, because we sometimes ask each other questions all the time about patients. So happy to be here. Thank you again.
Awesome. Have a good one.
Thank you. You too.